Okay, everyone. So we have our last speaker prior to our lunch break. So I just want to introduce Kiran Patel. Dr. Kiran Patel completed medical school and postgraduate residency training in the United Kingdom, obtaining accreditation as a specialist in general psychiatry, substance misuse psychiatry, and forensic psychiatry. He is a fellow of the Royal College of Psychiatrists in the UK, a member of the College of Psychiatrists in Ireland, and a fellow of the Royal College of Physicians and Surgeons of Canada. He practiced as a forensic psychiatrist in the UK for a number of years before moving to Canada. Dr. Patel is currently a staff psychiatrist within the forensic division of the Complex Care and Recovery Program at CAMH and assistant professor at the University of Toronto. He is clinical head for the Forensic Early Intervention Services, the CAMH partnership program with the Ministry of the Solicitor General. FEIS provides enhanced triage assessment and case management services to inmates at Toronto South Detention Centre and the Vanier Correctional Centre for Women. In addition to this leadership role, he undertakes clinical work at the Toronto South Detention Centre and the Vanier Correctional Centre for Women every week. He is a consultant to the Unified Mental Health Court at Old City Hall Courthouse and undertakes fitness assessments and provides psychiatric opinion on a weekly basis. He is medical head criminal justice interface at CAMH, leadership position directing and coordinating the various CAMH services and that directly interface with the criminal justice system. He undertakes additional work with Ontario Provincial Corrections and Correctional Services in Canada. Dr. Patel's academic focus and passion is translation of research evidence into best practice models and protocols through service development and innovation, driving and consolidating change, followed by comprehensive service evaluation. He plays a key role in the forensic research team, collecting and evaluating data related to the FEIS program. He is also involved with education and teaching development in relation to mental health within corrections, both provincially and federally. So welcome, Dr. Patel, and you are free to speak.
Wonderful. Thank you, Erin. I'm just going to share my screen. Hopefully that works out as I hope. Excellent. Let me see if I can make the slideshow work from the beginning. Oh, okay. So thank you to Justice Barnes and the whole of the team for kindly inviting me to present at this really valuable and helpful conference today. My topic is pretty wide, but I'll try and focus on important areas within it. I'm going to be talking about optimal and suboptimal states of mental health, but the focus being on what's happened more recently and also in some of the places where I work and where many of the folks who are attending today work. That's just a picture of our lovely new buildings at CAMH at Queen and Ossington. So what is mental health? What do we mean by that? Mental health is a state of well-being in which the individual realizes their own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to their community. And that's a WHO, United Nations definition. Mental health, in essence, involves finding a balance between all aspects of life, including the physical, the mental, the emotional, and the spiritual. And what do we mean then by wellness? Another a phrase that is commonly used. So wellness is not the absence of a disease or illness. It's the presence of a purpose in life, some active involvement in satisfying work and play, relationships which are joyful and positive, and interactions with others which are similar, a healthy body, and living environment, and a feeling of happiness in their person's day-to-day life. Wellness is a conscious, deliberate process that requires being aware of and making choices for a more satisfying lifestyle. A wellness lifestyle includes some of what I've described: a self-defined balance of healthy habits, including good sleep and rest, eating well, productivity, participation in meaningful activity, and positive contact with supporters. And this is work that's been validated over some period of time, all the way from the 60s to the current day. But to help us understand this better, I think it might be helpful to go back a little further to the work of Abraham Maslow. Abraham Maslow was an American psychologist studying human behavior and motivation. And in 1943, he formulated this pyramidal hierarchical concept of psychological health and human motivation. He divided it up with two sides: deficiency needs, where acquisition leads to reduced motivation, which is the bottom four segments of the pyramid. And the final top segment, which he described as being a growth need, where motivation actually increases as the needs are met. And what do we mean by each of these segments? How do we build from one to another? His view was that you did need to move from one stage to the next, but it wasn't hard and fast. There was areas of integration. But the concept essentially means that if you have deficits much lower down the hierarchy, the harder it is for you to be successful and progress up the hierarchy. And that makes a lot of sense. If you're concerned about shelter, clothing, warmth, sort of being able to sleep, being able to get 3 meals a day, and so on, you're not going to be worried about things higher up the scale. So physiological needs are essential. This is followed by safety needs, both physical security, law and order, but also emotional security, companionship, financial security, and stability within the society in which you reside. The next level up is about love and belongingness. The need for positive interpersonal relationships, a connectedness with others, both familial and non-familial, and throughout the wider community. Following this, we have esteem needs, the feeling of self-worth, accomplishment, and respect. Esteem both for yourself and the desire for reputation and respect from others. And then finally, self-actualization needs, the realization of your potential, the feeling of self-fulfillment, the seeking and attaining of personal growth, and experiences which continue to make you feel good and improve your feeling of well-being. As time progressed, Maslow revised some of his understanding and divided up the self-actualization needs in a more granular fashion. He added, for example, cognitive needs, the need for knowledge and understanding, curiosity, exploration, and the need for meaning and predictability. And we know that this is aided by residing in societies where education and the opportunities for education are there. The aesthetic needs, the appreciation and search for beauty and balance and form, and again, societies in which there is art and music and the creative arts, whether they be visual or other, allow us to appreciate and develop our aesthetic needs. And he put one above self-actualization. He put transcendence needs, the ability for that person to get to a point in life where they are motivated by values which are beyond the personal self, whether that be spiritual, whether that be nature or the pursuit of science or other aspects of higher functioning and higher understanding. And this is the sort of representation in pyramidal form of the greater Maslow motivation model. And I know there have been criticisms of the model by a number of psychologists subsequently, but I believe that the resonance remains significant. I accept that it is a model focused on the self more so than society, but as I say, it still has value in helping us understand and explain some of how human systems work and psychological health works. So what is mental illness? Mental illness is a diagnosable mental health condition or disorder. It's caused by alterations in how a person thinks, their mood and emotions or behavior, and is associated with significant distress and impairment in functioning. When there are changes in how a person thinks, their mood and behavior that cause such distress, it can be difficult to do daily tasks, and that may be constituting a mental illness. In the area of mental health, the word disorder is used to describe conditions which match a defined list of signs and symptoms. And the two main systems that psychiatry uses are the diagnostic and statistical manuals, 5th edition from the American Psychiatric Association, and the International Classification of Diseases, 11th edition now, which is from the World Health Organization. Oh, I think I've gone too far. Oh, there you go. How common are mental illnesses within Canada? Well, the mental illness is very common in our society. Up to 4 out of 10 of the leading causes of disability worldwide are due to mental conditions, and oftentimes mental health budgets make up a tiny fraction of healthcare budgets within most countries. And mental illness does not discriminate. There are significant issues in all countries and all societies. The rate of dementia, the rate of mood disorders, intellectual disability, schizophrenia have remarkable consistency across societies. What about Canada? In any given year, 1 in 5 Canadians will experience a mental illness or substance use problem. And by the time Canadians reach the age of 40, you get to a point where almost half the population have or have had a mental illness or disorder of one kind or another. The OECD average for healthcare budget spending on mental health care is 10%, and the Canadian average is about 7%, although there is provincial variation in that. And this is a nice quote from our previous CEO at CAMH. Mental illness, including alcoholism and substance misuse, affects 6.7 million Canadians, 20% of the population, yet many Canadians do not have access to the treatment they need. Nearly 4,000 Canadians die by suicide each year, 1,000 of whom are children. We must do more to address the health, economic, and social justice issue of our time. And I think many of you will have seen the campaigns that CAMH has run in recent months regarding mental health, and particularly about the risks of suicide and supporting people who are feeling suicidal. So what causes mental illness? What are we talking about? Well, despite all the money spent and all the research, we still can't say for sure what causes each and every mental illness. What we do know that in broad terms, it is a mixture of factors which contributes to the development, the onset, the recovery, and indeed the severity of most mental health problems. It is that interplay between genetics, biology, the environment and experiences, and physical conditions. And the combination of these factors is different for different conditions. I mean, one thing that we've always tried to inform others about is whatever the cause of mental health problems are, they are not the individual's fault. And that is a historical stigma that has existed with mental health for essentially forever, which we continue to grapple against. No one chooses to have a mental health problem, and we need to remember that when we are trying to support folks with such difficulties. And bringing it back to the Canadian context, what makes Canadians sick? And this is a survey conducted by the Canadian Medical Association in 2013. And you can see that, biology and genetics has about a 15% effect on what makes you sick. But your lifestyle or your life has a much, much larger impact. Who you are, your income, your development, your education, your social status, your community, whether you have stable housing, race, Aboriginal status, employment, and so on. And so those have a significant and greater impact on whether you become sick or not. And I think everybody here will have heard about the social determinants of health. And this is a graphic reminder of how impactful those determinants are. So this brings us on to, I guess, the defining event of our time. And I wanted to take a few minutes to talk about COVID-19, because ultimately mental health has been hugely impacted by the pandemic, and the pandemic continues to exert enormous influence on the mental health of our population. And so let me just take you down a perhaps slightly unpleasant memory lane of the COVID-19 timeline in Ontario. So in January of last year, we got our first case, and we started rapidly changing how we lived our lives. We all started washing our hands incredibly often. We all started to look for masks, particularly within healthcare, but others too. We were practicing social distancing, and everybody was trying to source PPE across the world. And some of you will recall some of the difficulties that Canada had obtaining PPE at that time. In March, we had the first death from COVID in Ontario. We had sports activities shut down, music activities shut down, followed by the school shutdown, the state of emergency, and the full shutdown, as well as the first border closures with the United States and internationally as well. That carried on for about 2 months before we started our first staged reopening. That was partially successful, and the schools ran for a few weeks before the summer break, and then the reopening in September was with hybrid learning. We got to a point where we were doing fairly well in September, October of last year, and then we got into the second stage, or the second wave, should I say. And then that led rapidly to the second lockdown, which continued pretty much until the end of the year. But there seemed to be light at the end of the tunnel with the initiation of vaccinations at the end of December of 2020, and then expansion of the vaccination program from 2021 onwards. And then this year, we've had the staged reopening from the spring, the evolution of the vaccine certification system in Ontario, but then we had the Omicron variant identified just a few weeks ago. So if anybody's been keeping up, we've had 4 waves of infection in Ontario so far, and we're still learning about the potential impact of Omicron and making changes based on that as well. So what was the impact on mental health? Well, the first wave was had the greatest impact because this was something new. It was something frightening, and it was something that people were struggling to understand. And so the anxiety, stress, worry were the initial feelings that people were experiencing. People had fear for loved ones and for their individual health and safety. There was social isolation, both intended and unintended. There was psychological distress, low mood, poor sleep, negative thoughts and cognitions, because people were fearful of what was happening and worried about what the future may hold. There was a gradual loss of autonomy as the federal and the provincial governments made more and more changes to what you were able to do. And we recognize and remember the disproportionate impact on those in congregate living settings, residential homes and shelters and jails. I think everybody remembers the immense sadness and tragedies of Bob Cajun and the residential homes early in the crisis, and the sad loss of so many of the elderly population in those places. There was frustration at the perceived resource failures the masks, the PPE, and so on, there was people getting COVID, and the hospitals learning how to manage those individuals, treat those individuals, and support them in their recovery. There was, and to some extent still is, stigmatization and alienation of certain populations and groups, and that impacting their mental health even more. There was an increase in maladaptive coping strategies, the use of substances, the use of alcohol, and it was all that much worse for those with pre-existing mental health difficulties. So the first wave came and went, and we made changes and we learned. But the second wave again washed over us, and there was worsening isolation. But now there was job losses and income losses, partly managed by the federal and indeed the provincial government with emergency responses and CERB and other measures. But it didn't help everybody, and it didn't help everybody in the same way. There was anger at the government, anger at COVID, anger at others. There was ongoing loss of control, and there seemed to be increases in suicidality and self-harm, and there was a considerable worsening of non-COVID health. Just as all of the hospital services were gearing towards managing COVID, the non-COVID side, both the physical and the mental, was struggling because there's only so much health resource available. And then the third and the fourth waves, which have been in 2021, led to new experiences, the onset of vaccination and the fear of vaccination, people's concerns regarding what vaccination meant, the safety of them, and their concerns that this was something that they did not have choice over. The anxiety and fear of returning to work or to school, and the concept of the new normal. What is normal now? The psychic and psychological trauma effects, the scarring, the damage of COVID over the last 2 years continues, and the economic injury again has had a significant impact. There's been areas of particular stress and burnout, healthcare workers, long-term care workers, police, corrections, other essential workers. And there continues to be now stigmatization, but of a new group, the non-vaccinated group, and those who are going to struggle with being able to resume their previous activities, and a perceived loss of status for those individuals as well. So everybody was impacted by COVID, that is clear, but not everybody was equally impacted. And there's been quite a lot of research in 2020 and 2021 in Canada, in the US, in Europe, and indeed across the world about the impact of COVID on mental health, societal functioning, and physical health. A quote from Jenkins's paper, the differential mental health impacts of COVID by gender, sexual orientation, household income, ethnicity, mental health, and disability is quite evident. We also need to think about who had the higher risk from COVID. There were those who could not stop working, the essential workers in our community, those who had to live in larger groups, both because that was a necessity, so residential care homes, correctional institutions, or because that was the only way that they could survive, whether that would be congregate living settings with multi-generational households. And those with those pre-existing physical conditions and those who were immunocompromised. So I think social determinants of health has been mentioned in the previous talk this morning, but I think it is such an important area that it's impossible to work in our field, in health, mental health, or in criminal justice without really considering it at all stages. What do we mean by determinants of health? And then we can talk about the social determinants. So as I described earlier, there are many things which affect our health which are not directly related to our biology or our genes. It's a broad range of personal, social, economic, and environmental factors which have an outsized impact on our health. The most important three that have been identified would be income and social status, the childhood experiences that a person has, and social supports and coping skills. But for many within our society, there are additional factors which have significant resonance, and that's race or racism, culture, gender, and factors such as employment and education. So we know that the social determinants of health refer to specific groups of factors, and they relate to that person's place in society. And the particular folks that we have concerns about in our society include Indigenous populations, LGBTQ populations, and Black Canadians. And we know that there is significant health inequality and health inequity. Health inequity being inequalities that we know can be demonstrably unfair or unjust and modifiable. So I want to introduce syndemic theory, which builds on the social determinants of health, and really it describes how health and social disparities emerge from the interaction between disease states and the social, environmental, and economic forces that worsen disease outcomes. So just linking in that those two pieces, which is the individual and the conditions that they may experience, and the social environment which impacts upon it. And it explains why the mental health consequences of COVID-19 have been so much more concentrated among structurally vulnerable groups due to that interaction between the virus, comorbid health conditions, racism, poverty, exclusion, and discrimination. And it helps us lend support to the need for that collectively oriented policy level solutions to address the health of individuals, but also of populations. And this is a neat quote that I got from a paper from Horton describing the impact of COVID-19 and connecting it to the social determinants of health. No matter how effective a treatment or protective a vaccine, the pursuit of a purely biomedical solution to COVID-19 and indeed the impacts of COVID-19 will fail unless governments devise policies and programs to reverse profound disparities, our societies will never be truly COVID-19 secure. And I think he's talking about not just the illness, but the impact of the illness. So that brings me to the criminal justice impacts of COVID-19 and the mental health difficulties associated with it. So what happened to criminality following COVID-19? Well, we know I work in three different provincial correctional institutions and a federal one. We know right at the beginning, there was actually a reduction in crime, particularly acquisitive crime. Why? Everything was locked down. And so it was an environmental change which led to a change in the sort of the criminality that was undertaken. But there was increases in specific crimes. And this was not just in Canada, but multi-jurisdictional. There was increases in domestic violence, again, because of lockdown and the people being in close proximity for much longer periods of time than they would have otherwise. There has been concerns of increased child abuse, and there was a significant increase in fraud and e-crime, again, because that was more of an option, because a lot of programs came into being, which were mechanisms to get money and resource and welfare to the community. Has there been a return to normal? Somewhat. There has been some changes back to where we were, but I don't think it's quite what it used to be just as yet. What changes were there in policing and courts? Well, especially early on in the pandemic, there was differences in how minor crime was addressed. Folks got more warnings and reprimands. There was a reduction in remand orders, and there were more community sentences. There were more virtual courts and a pivoting of courts to the use of video and audio hearings, and a number of changes to streamline the process and increase the use of remote working. And I mentioned Bill C-23 as this is something that's essentially come about because of COVID, to amend the Criminal Code and the Identification of Criminals Act to make the amendments that were made because of COVID, such as some of the criminal procedure changes, remote proceedings, tele-warrants, fingerprinting, to try and make some of those permanent because they were less onerous in the new way of working. In my area, in prisons, there was a significant reduction in the number of prisoners, especially in the early part of the pandemic. Between sort of March and August of 2020, there was a significant prisoner release and reduction in the population, and that was really quite marked. There were changes in the visitor policy, and those changes are still in place. There was a development of a prison cohorting and staging process to better separate new individuals coming into the prison system from individuals who have been there for some time, to prevent the spread of COVID-19, and the enhanced efforts to support external contacts through telephone contacts. I mean, obviously that was a necessity, bearing in mind that the visitor policy meant that both face-to-face and video visits were significantly curtailed. So something to think about We've come a long way when it comes to COVID-19 and the impacts on mental health and the criminal justice system. And I wanted to just mention that the new normal is going to be different from the old normal. And partly is because the pandemic has continued to evolve. The hope that this was a short-term event, probably in the early part of 2020, was dashed as each new wave of infection came over. And then the sort of miraculous hope of vaccination again did not yield the level of change that everybody was hoping. Vaccination is incredibly important, and it's made a tremendous impact on the number of people getting sick and the number of people requiring hospitalization, and indeed the number of people who are succumbing to the virus. But as we have adapted to the virus itself has adapted and mutated, and so we remain in a position of quite elevated vigilance as the new variants emerge. And so equally, the anxiety and psychological distress within society remain elevated. We continue to be in a position where certain populations continue to be more affected than others. There's been impacts on social and societal cohesion. There's been widening of existing gaps as opposed to narrowing, and there's been new gaps which have emerged, which has the potential for significant societal angst. I mean, the one I would say is the biggest is the vaccinated versus unvaccinated groups within our society. Suboptimal mental health continues, and this is something that we need to consider because it may well be a longer term phenomenon. I wanted to make a pitch for mental health promotion as opposed to just prevention and treatment. And mental health promotion has grown in interest in the last 2 years. And using a public health approach to include promotion in addition to prevention and treatment may be a way of improving some of the difficulties that have been highlighted by the pandemic, the suboptimal mental health of the population. It's a critical and underutilized element of a comprehensive mental health strategy. We focus on treatment, we focus on prevention, we focus on identification, but promotion of positive mental health may well be something that will have a significant benefit to our society. Promotion it's a strengths-based orientation aimed at enhancing the positive aspects of the individual, the community, and the population, and includes those experiencing the greatest vulnerability or risk. And it includes strategies to build self-esteem, to enhance and develop coping abilities, and to improve the sense of well-being. In partnership with that, there has been the development of a new movement. Some may well have heard of this movement already, and there are chapters provincially, federally, and in other nations, which is it's been called a just recovery movement, and there are minor variations in the aims, but the just recovery movement in Ontario and in Canada generally has the following six elements: putting people's health and well-being first, strengthening the social safety net, providing relief directly to people, prioritizing the needs of workers and communities, building resilience to prevent future crises, building solidarity and equity across communities, generations, and borders, and upholding Indigenous rights and working in partnership with Indigenous peoples. And I think the just recovery movement, in my mind, works well with the social determinants of health. And indeed, in my mind, it builds on Maslow's hierarchy of needs as well. Interestingly, the criticism of Maslow was it was ethnocentric. It was based on a particular point in time. It was based on more individual concerns as opposed to societal concerns. But Maslow spent time with the Blackfeet Nation of Montana, and actually took a number of ideas from North American indigenous communities as he developed his hierarchy. So I think bringing all these things together hopefully will allow us to improve mental health generally across our society, and to build that strength and resilience for managing the current pandemic as it evolves and onward into the future. Thank you.
Thank you very much, Dr. Patel. We have a couple questions here. So the first one is, as the pandemic progressed, what could we have done better to manage the mental health needs of individuals within the criminal justice system?
So I think there's a lot to be, there's a lot we can take which was positive in the approach we took. But I think we could have done better in terms of keeping more people out of jail. And I think that was a positive thing that was done in combination with Crown attorneys, judges, defense counsel, community providers, and others to keep people out of custodial environments. But I think there was more we could have done. If we'd had better shelter supports, better community resources, we could have kept more people out, and some of the people who got sick because they went to jail perhaps may not have got sick. And the second piece I would say is we could have developed the cohorting, the staging units within corrections earlier. And again, many in this audience will know how prisons work. They have, especially provincial facilities, where you have a rapid turnover of individuals. You have new people coming in, people leaving, and it's a very hectic environment where people are moving around on a daily basis, and that's absolutely the worst thing you want when you have an infection which can rapidly spread. And having those cohorting and staging units, as we have them now, makes a phenomenal difference. And if we could have developed those, even 2 or 3 months earlier, I think that would have been very impactful also.
Absolutely, absolutely. Okay, and the next question is, how do you see mental health problems and suboptimal mental health within society evolving over the next 1 to 2 years?
I think it's a very valuable question.
Mhm,
The first thing I have to say is, well, it depends. It
mhm,
depends. It depends on how the pandemic continues to evolve and what is defined as the return to normal. And I think there are going to be permanent changes, and some of those permanent changes are going to be positive, whether that be less people getting remand orders, more people getting community sentences, more people getting bail, and continuation of criminal justice pathways in the community. But there are going to be some negative elements too. There are going to be people who are having that suboptimal mental health because COVID has had that impact on their life. And I would say that we need to make sure that we catch those who are struggling, but we also promote good mental health and good mental health well-being for the majority, so that we give them that resilience to achieve the best quality life that they can have.
absolutely. And just one comment left here. An individual by the name Abdul said, I think the triangle, so he's referring to Maslow's triangle, I think the triangle should be reversed. Everyone needs to be met for individual to actualize.
Uh, I see where you're going, but I guess if ultimately if you're worried about your next meal, or you're worried about staying warm, or you're worried about where you're going to sleep that night, it's going to be difficult for you to reach the top of that triangle. But as a society, if we use some of what was described in the Just Recovery movement ideas, we can move people up that triangle. It shouldn't be that only a small number of people are at the top of that triangle, and I think that's where the hierarchical piece struggles. It shouldn't be a triangle. Everybody should
Mhm,
be able to achieve the top of that triangle. And as a society, we have to make those choices to be able to get the majority of our population up through and living the best life they can.
mhm. Absolutely. Thank you very much for your very valuable time, Dr. Patel. Great insight, great presentation there. And we were very honored to have you speak today. So thank you very much.
Thank
Take
you.
good care.
Bye bye, everyone.